Okay, so hello everyone and welcome. Thank you for joining us. My name is Martin Eichenlaub and I'm an electrophysiologist at the Department of Cardiology and Angiology at the University of Freiburg. And it is my pleasure to moderate today's debate on universal screening for atrial fibrillation. Should we do it? As you all know, atrial fibrillation is the most common arrhythmia affecting approximately 1 in 3 individuals over 40 years old, and the prevalence is expected to at least double over the coming decades, driven by population aging, an increasing burden of comorbidities, and improved detection and awareness. And atrial fibrillation is strongly associated with stroke, cognitive decline, heart failure, hospitalization, and mortality, and therefore has a substantial impact on healthcare systems across both primary and secondary care. However, up to 1/3 of all atrial fibrillation cases are asymptomatic at the time of diagnosis and hence remain undiagnosed and untreated. The rapid expansion of screening technologies, ranging from simple pulse checks and handheld ECG devices to wearable sensors, smartwatches, and prolonged monitoring strategies, has made the question of who to screen, how to screen, and whether increased detection of atrial fibrillation truly translate into meaningful clinical benefit, or whether increased detection only risk causing unnecessary patient anxiety and increased use of healthcare resources in an already strained system. So I believe that the clinical debate is no longer whether atrial fibrillation can be detected earlier, but rather whether earlier detection through broad screening leads to a net clinical benefit for patients. And I am very pleased to be joined by two outstanding experts to discuss this important topic. And it is my pleasure to introduce Dr. Laurent Fiorina. He's an electrophysiologist at the Cardiovascular Institute in Paris, in France, and he will be arguing in favor of universal screening. And Dr. Sandrine Venier, she's an electrophysiologist from Grenoble, also in France, and she will be arguing against universal screening. And thank you both very much for joining us today. And we will begin with your statements and arguments and then move into a discussion and finish with closing remarks and key take-home messages. So Laurent, the floor is yours. Please begin with your statement.
Hello. First, thank you for the invitation. I'm very pleased to show you my points in favor of the screening. So I think first the screening is fundamentally about having the right tools. And for sure, when Wilhelm Enthoven invented the first ECG, it was not the same, it cannot be the same strategy than nowadays. My disclosure is that also as an EP, I also co-develop Cardiologs. It's an AI startup that makes AI ECG interpretation, now acquired by Philips. So after Wilhelm Enthoven, a major disruption came with the ability to record ambulatory ECG, initially using a 80-pound backpack. So this is the first case of Norman Holter, who published this in the 1950 Rocky Mountain Medical Journal. And this permitted the ambulatory recordings. So as you know, now we have a lot of devices and patches that can record as long as 1 month ECG, and with also AI algorithm that permit to make it more easier, avoiding all the noises and artifacts and all the false positive. And more recently, so this is one of my patients, more recently, a true revolution occurred with the miniaturization and the emergence of the smartwatches. Because the smartwatches have the capabilities to screen AF with the PPG. And the main brands like Apple, Samsung, Huawei, they conducted very large studies showing high PPV for the AF diagnosis, above 90%. And I think this pushed the guidelines, and I think Sandrine will talk about it. But now in Europe, and it's consistent with the guidelines in US, it is recommended to screen for AF above 65, and they talk about non-invasive ECG-based approach, which include this kind of tools. So as you said it, Dr. Eichenlaub, there is the problem of the asymptomatic nature of AF, but also the paroxysmal nature of AF. And often the question is about the duration of AF. Is it valuable to screen for very short duration with a low SHADS-VA? And the point here, it's a table that was in the guidelines that showed that AF begets AF, and even if you screen for short time duration AF, if you wait 6 months, 1 year, it goes through longer episodes with a higher risk of stroke. There is this study that shows that undiagnosed AF is very common. In US, about 1.5 million of AF. And of course, the problem is, as you said, this is a highly prevalent condition, 1 to 2% of the population, and it causes a stroke. And approximately 20% of these strokes are linked to unknown AF. So the question for screening is to diagnose this AF before the stroke, to act before and to avoid eventually the stroke. And also often it's there is a comparison between silent and clinical AF, but silent is more dangerous than clinical. There are many studies that shows that the odds ratio it's at 3.5 for stroke, and all-cause mortality 3.1. So silent AF and paroxysmal AF doesn't mean that is a benign condition. So about the anticoagulation, there are many studies about anticoagulation, but in fact the question is where to put the cursor in terms of burden of AF and SHADS-VA score. Also, there is a way to reduce maybe stroke without incrementing the bleeding risk. There are studies about pill in the pocket for anticoagulation. And there are also hopes in the new kind of anticoagulations. So in the question of avoiding stroke with anticoagulation, it's a matter of risk and benefit, and there is a place to put the cursor where it's the best. But we have to keep in mind that it's not only about stroke. AF begets also heart failure, dementia, conduction tissue disease, and impair the quality of life. And it is now in the guidelines that you should have a global comprehensive for the AF management. So it's not only stroke, but also the comorbidity and risk factor management, the alcohol intake, the weight loss, hypertension, diabetes. And there are also recommendations for primary prevention. So we can guess that we know that with an early AF diagnosis, we can stop the process of AF and atrial remodeling, acting on the comorbidity factors. And looking ahead, the file is also moving from diagnosis to prediction. As you may know, now there are AI ECG that can predict AF from a sinus rhythm. So this work is from the Mayo Clinic, that shows very good AUC to predict from a sinus rhythm. There are also proof of concept that we can make a short-term prediction of AF from a single lead ECG. So we can think also that before the manifestation of AF, we can act also on the cofactors, and maybe there are places for studies in this area for early stroke prevention.
Thank you, Laurent. It's my pleasure to continue the presentation with the against side of the subject. So we know that atrial fibrillation has a lot of consequence: heart failure, dementia, strokes, and so the rationale for screening is clear. 10% of ischemic strokes are caused by AF, first diagnosed at the time of the stroke itself, and over a quarter of AF-related strokes occur with no prior atrial fibrillation diagnosis. And asymptomatic AF is not benign. In untreated patients, stroke rates reach 4% and mortality 7% at 18 months. And the anticoagulant brings both down dramatically. As Dr. Fiorina said just before, we have a lot of tools for AF screening now: the classical Holter ECG, and the smartwatch, the internal loop recorder, and the classical with just the capability to detect the regularity or irregularity of the pulse, with a constant improvement on the accuracy of the devices, but how and who to screen. If we look at this big study, Apple Heart study, with more than 400,000 participants, with a huge population and a broad population, more than 22 years old patients were included. And then on this population, only 0.52% received irregular pulse notifications, with a false alarm rate overall 16%. And when we see more closer, we can see that the alerts concern mainly the older patients than 65 years old. So it's important to target the population, because in term of diagnosis, it's not concluent on all the population. So it was a proof of concept to be able to detect atrial fibrillation, but no, we are far away the stroke reduction demonstrated. Now, when we target the population for the screening, the Screen AF trial, it's a controlled randomized trial with 856 adults aged more than 65 years old. They are randomized comparing usual care versus home-based screening with 2-week continuous ECG patches. And then, of course, we see that new AF detected is high 5.3% of the screening group versus 0.5% in the controls group. So it proves that we screen more AF with the home-based screening, and 75% of patients with screen-detected AF were started on anticoagulation. So there is a big impact in terms of treatment, but the trial was not powered for stroke outcomes. So it doesn't conclude for a benefit to screen this population in terms of strokes. So we have the second randomized control trial, the Stroke Stop trial, with 28,000 patients randomized in the screening group versus control group. The screening group were invited to AF screening with intermittent ECG twice daily for 14 days. And anticoagulation was started when AF was detected. And the primary outcome is a composite outcome: ischemic stroke, hemorrhagic stroke, systemic embolism, major bleeding, and all-cause death. And when in the screening group, we can see a small effect benefit for the screening group in terms of primary composite endpoints, but there is no proof for just stroke decreased, because it was not designed for that. And then it's a beginning to show that we have to screen to decrease the risk of stroke, but we need more controlled trial. And if we take Artesia trial, which take all patients implanted with pacemaker, defibrillator, or internal loop recorder, randomized apixaban versus aspirin, when we had more than 6 minutes of atrial high rate arrhythmia, we can see that in the apixaban group, we have a decrease of stroke, so it's important, it's a benefit, but we have a higher events in terms of major bleeding. So the net clinical benefit is debated because there is more bleeding. And if we look at nuanced, the same design preceding the Artesia study, edoxaban versus placebo, it stopped because of the non-benefit of the study. And so the guidelines, the European guidelines are in line with these results, and routine heart rhythm assessment during heart-scar contact is recommended in all individuals aged more than 65 years old. And population-based screening for AF using a prolonged non-invasive ECG-based approach should be considered in individuals aged more than 74 years. So it has to be a targeted population. And even in the targeted population, we have to be careful in the screening. And the benefit of the screening, we know, it's to detect atrial fibrillation, to decrease the comorbidities related to atrial fibrillation, but the risk of abnormal results are not benign, because it can cause anxiety with the patient, some over-diagnosis with ECG misinterpretation, and we need the medical resource to be able to see all these patients with all these alerts. And then probably we still lack strong randomized trials showing clear benefits on major outcomes like stroke, with the risk of false positives. Not all detected abnormalities are true clinical AF. And the cutoff of the duration of the AF to treat is difficult to know, as Dr. Fiorina said. So the population has to be targeted. Opportunistic screening from age 65, okay, but universal screening, we are not ready for that. And probably the artificial intelligence will help to know, but currently that's it. Thank you.
Thank you very much, Dr. Venier. So I think you pointed out a lot of important issues, and maybe Laurent, I will hand over the first question to you. So Sandrine showed a lot of studies, and there are other studies like Loop and so on, showing that prolonged screening detects more atrial fibrillation. I think there is no doubt. But do you think is increased detection enough, or should we really demand consistent evidence for stroke reduction, mortality benefit, and net clinical benefit before implementing screening at scale?
Yes, so those are a very interesting study, but they are really focused on stroke reduction. And as I said, it's not only about stroke. There are a lot of other comorbidities, maybe to stop the process of AF with cofactors, and also looking more precisely on those studies. For example, the Loop study, the Shatzva score was at 2, and they took 6 minutes AF episodes. So maybe taking longer episodes and higher Shadzva, because there was a trend into reduction of stroke. So maybe this could reduce significantly stroke in certain populations. And also in the Arrhythmia study, which is a special population of patients with implanted devices. So that there is debate on this. But in Arrhythmia, they show that the strokes reduction was mainly on severe stroke, meaning that the Rankin score showed that there was a lot of disability and very bad strokes, I mean. And the reduction in the very bad strokes with a lot of disability were significant, about 50%. While the hemorrhages, the bleeding, was mainly digestive bleeding with transfusion, but with no more disability, you know. So and I think that there could be some strategies to reduce the bleeding risk. But really, my point is to say that it's not only about stroke reduction. We should focus on the reduction of also the process of AF progression.
Mhm. But I think there also that we need more studies and data to really confirm that this is the right endpoint, maybe. And Sandrine, what do you think? So, is the 30-second definition still the right of atrial fibrillation, still the right endpoint we have to screen for, or is it more AF burden or maybe stroke risk, or what would you suggest?
Probably, we know that just 30 seconds of atrial fibrillation in 1 year, it doesn't matter, and clearly this is a burden that's matter. In the recommendation, we have to treat and to ablate the symptomatic atrial fibrillation. This is the first point for the problem, because if we want to treat the asymptomatic atrial fibrillation, the recommendation have to change, because if we do the screening, we will have a lot of 5 minutes, 1 hour, 6 hours of atrial fibrillation. And we know that if we don't do anything with the years, the burden will increase, and then we will have the persistent atrial fibrillation, and then it's too late to treat correctly the patient. So we have to put the cutoff and to change the recommendation. And for that, we need some more randomized control trial, probably a trial with the screening and with ablation with asymptomatic atrial fibrillation that it's lacking.
Mhm. Okay, so Laurent, you showed us 2 studies using artificial intelligence. So the first one, the landmark trial by Atia from the Mayo Clinic. This was, more essentially a black box model. So we do not really know what the artificial intelligence is looking at, which patterns and so on. And I think your study, this was more explainable. AI was used within the study. And what do you think? How much interpretability do we really need from artificial intelligence models before we can apply them in routine clinical practice? And also base then our clinical decisions on their outputs, of course.
Yeah. So for me, the key point is the performance of the model, the AUC, and the generalizability in different populations. So for me, explainability is nice to have because it makes reassurance for the physician. So as you said, we made it for the study we run with the cardiologs, and we made the explainability of our model that predicts AF at 2 weeks, and that shows that the AI was looking on the P wave, which is quite logic for us. But sometimes the AI could look other patterns that don't seem as evident, obvious for us. So yes, explainability is nice to have, and people who make AI models, they try to do it. now, but it's not the main point for me.
What is your opinion in this case, Sandrine?
There is a lot of studies with AI, and each one with the AI. A lot of Chinese studies, for example, to predict strokes with the P wave on Holter or other tracee. Probably in the future, if we are able to predict AF and AF associated with stroke with sinus rhythm ECG, it's the key. Because when the patient will make atrial fibrillation, he has an EKG with a prediction of stroke in addition, and then probably he will be a better target to begin anticoagulant than the other one with atrial fibrillation, but with a normal left atria without risk of stroke, in order to decrease the bleeding risk to anticoagulate the wrong target. So AI probably will help us. We need to improve with studies and to unify the things, because there is a lot of AI difference, a lot of different studies in different countries, and so it have to be to continue.
And I think you both pointed it out. It's also important to train the algorithm with the right endpoint, let's say. So should we use atrial fibrillation, so new onset atrial fibrillation, again, probably a low burden, or should we train the models with stroke endpoint or AF burden endpoint? And I think there are a lot of open questions how to train our models. And Laurent, you also pointed out the reproducibility. I think this is also a very important point. So everyone is talking about AI, but I don't know if are there a lot of AI applications included in your clinical routine already? Because I have the feeling that there are a lot of algorithms, different algorithms, but not many are still used in clinical practice.
For me, yeah, the main AI model we use is the one from cardiologs, Philips, for Holter ECG analysis. So it's for diagnosis. For now, there is not a lot of predictive model on the market, but I'm sure it will come in the following year or 2 years. So it's a question of time. But now it's more for diagnosis and to have a more fast results and to diagnose more patients who have Holter ECG patches, which is a great way to screen for AF in a certain population.
And Sandrine, in your hospital, do you already use a lot of AI tools, or?
We don't use AI tools in the clinical practice. Currently, AI is used in research with the team's laboratory, but not in clinical practice.
But as you showed, the guidelines are now very broad, so you have to screen for every patient with over 65 with one risk or over 75 without any other risk. And it is not done actually. It should be done at least with a Holter ECG. But there is some way a data deluge with a lot of data to treat. And for that, we need for sure AI and the future should be a way to automatize this screening to make it more automatic without the need of physician or technician to read each ECG and each Holter. So maybe to make it more easy with the AI.
And I think screening programs require a lot of resources, right? And what is your way to go? Should we, as you pointed out, Sandrine, go for opportunistic screening, really during the routine care? Or should we go for systematic screening in older adults or adults at risk, or consumer-led wearable detection? So what is your way to go? What do you think?
I think we have to do more systematic screening on the population more than 65 years old, because we have too much strokes, which makes the diagnosis of atrial fibrillation in the same time. So we have to avoid all these patients. And currently, more and more patients have smartwatch or connected device, and all patients we see for the detection of atrial fibrillation, when they consult for palpitation, for example, they take a connected device. So we have a lot of population of patients with connected device, and we make the follow-up with the telecardiology, our telecardiology team, and that's it. But it's our practice, and we have to extend this, I think, with the asymptomatic patients in the older population more systematically. But we probably not have the medical resource yet, or we are not enough or great organized to absorb all the patients in systematic screening. But it's the right thing to do to improve the systematic screening of the older patient.
Mm-hmm. And what is your opinion, Laurent, in this case?
I agree. I think we have to perform more widely screening over 65 years old. You know, there is about 1 million stroke in US and 1 million stroke in Europe each year, and 20% of them are linked to AF, undiagnosed AF. So we have to catch those patients, and the only way to do it is to screen. So I think above 65, patches or Holter ECG is great. And otherwise, the smartwatch ECG is a real revolution, because the patient, they don't ask the physician, they don't read the guidelines, they only screen themselves. They buy a watch and they screen themselves. And you know, in US, it's about 1/3 of the population who has a smartwatch. In Europe, is a quarter maybe, and it will get more and more used because it's quite affordable. It's an easy technology for all the brands, and there is a real patient empowerment. And the question is maybe no longer whether to screen, but how to act on the early detection in a patient who has not the criteria for anticoagulation, but what to do with this early AF, because we know that this early AF will become dangerous AF someday. So I think it's good to know when you have a disease like that, even if you don't start an anticoagulation.
Mhm. Yeah, I totally agree. And I think it's also important to really motivate the patients to participate in screening programs, because there are also some data that patients who will not participate in these screening programs and refuse to participate. These are the patients really at risk with low socioeconomic classification and so on. And therefore, I think we really have to also motivate the patients to participate in the screening programs. Yeah. So yeah, thank you both very much for this excellent discussion and for sharing your insights so clearly. And I think now we can move on to the closing statements. And I would ask you to summarize your position and your main take-home messages for our audience, and maybe Laurent, you can start.
So yeah, I think it's crucial, as I said, to have an early diagnosis of AF, even if you don't start an anticoagulation. It's not only a question of anticoagulation. And the only way to reduce the burden of stroke is to have an early diagnosis of AF. And we have now very affordable tools. We have Holter ECG, patches, smartwatches. So I think we have to use it in the line of the guidelines, but I would push a more widely screening than the guidelines.
Thank you. And Sandrine, your statement, closing statement.
The closing statement is very close, but I think so that we are not ready for a universal screening. We have to be ready for a more extended screening in the older population, and we have to do this in the good way. And when we are ready, we can extend in all population, younger probably. But the evidence systems and resources are still insufficient, so we need more big control randomized trial with programs for screening, and it's important to continue with the research on that.
Okay, so I think it remains an exciting and evolving field. And so thank you very much again, both of you. And we hope you enjoyed our debate, and thank you for joining us.